Good morning. I'm Susan Dentzer. My day job is as editor-in-chief of a journal called Health Affairs, which we like to think is the nation's leading journal of health policy and an important journal in the field of global health policy as well. But I'm delighted to be here today for several reasons. I also have an addiction to higher education. I graduated from Dartmouth College and became a member of the Board of Trustees of my alma mater a number of years ago, served as chair of the board of Dartmouth, and continue involved in the medical school where I'm on the Board of Governors. So I've had a longstanding interest in higher education and therefore am particularly delighted to be here on this occasion. There is nothing so momentous in the life of a great university as the installation of a president. And to me, the installation of a president bespeaks that wonderful combination of transition and continuity, the dynamic interaction of change and permanence that characterizes all great institutions. The permanent part being the commitment to higher education and education of young people and the advancement of knowledge and scholarship. The transition part being that all of those things are always changing. Knowledge is changing. Structures of society are changing, at least to some degree. And the institution always has to take those into account as it reinvents itself so continually to be relevant to the future. And that is precisely what a terrific university like Stony Brook has done in putting Dr. Samuel Stanley here to lead the university going forward. You know Dr. Stanley's extraordinary background. I won't dwell on it except to say that he's uniquely positioned to be leading this university at this time, and particularly to embrace all of the opportunities that await it in the global health field, which is our topic today. As you know, global health, America's health, moral imperative, strategic necessity. If we had been here 10 years ago, many of you would not have been in this room because of the enormous changes that have taken place in the global health field over the last 10 years. You are. When we think back to just the year 1999 or 2000, for example, there was no UN AIDS. There was no PEPFAR. There was no global fund. Even though there had been so many long-standing scourges that had affected developing and poor countries for so long, the world simply had not organized itself to quite the same degree that it has now organized itself to combat many of these conditions. Now, that doesn't say that the job is over, but look at what has happened over the last 10 years. 4 million people around the world on antiretroviral therapy, from a fraction of that just a few short years ago. Things that people thought were just impossible. Remember, it was only about 2001, 2002 that some of us in this country believed that Africans couldn't be put on antiretroviral therapy because they didn't have watches, right? This was actually something said by an official of USAID. So there have just been extraordinary changes. Look at the rate of decline in the deaths of children under the age of 5, child mortality around the world, the enormous changes that have taken place there, in part because of the advent of vaccines, as we will hear more about later today. So there's just been an extraordinary amount to be grateful for, an extraordinary amount to be hopeful about, an extraordinarily long way to go. And that's really going to be the topic of our discussion today. With, as we know, as many as many people around the world as being on antiretrovirals, we still know that probably 7 million more people around the world should be on them. We know, for example, that neglected diseases continue to plague the world and actually hamper not only the cognitive development of millions of children around the world, but economic development as well. We know that the scourges of malaria and tuberculosis remain very much with us. We know that malnutrition and starvation still characterize much of the poor world. But we also know that that is cheek by jowl, if you'll forgive the phrase, with the growing problem of obesity. You may know that the World Health Organization several years ago announced that the number of people overweight and obese in the world had risen to the level that was identical to the number of people who were starved or malnourished. This is an extraordinary development in global history and one that many of you will be increasingly combating. We know that we face ongoing challenges in those arenas, but that we will also face new challenges as well, from climate change, for example, from evolving infectious diseases. I give you the H1N1. And we know that we have many, many challenges just dealing with things that we know how to solve, but just haven't risen to do. And I give you, as the foremost example of that, the Millennium Development Goal number 5, which is to sharply reduce maternal death rates, something very simple that we know how to do. 500,000 women around the world still dying in pregnancy or childbirth, extremely preventable, and we haven't done it. We haven't gotten to the goal, and it's probably the goal that we're least likely of all the MDGs to make headway in by 2015. So many, many challenges ahead. Well, part of Stony Brook's mission statement I read is to carry out research and intellectual endeavors of the highest international standards, to provide state-of-the-art innovative health care, including resources to the underserved, and to fulfill all of these objectives while celebrating diversity and positioning the university in the global community. And I have to say the posters that many of us were able to see this morning just underscored how alive and well that mission is here at Stony Brook. I consulted with a few people, just to mention one, Tiffany Channon, from a clinical laboratory sciences graduate who had just gotten back from some work in Africa, basically helping people understand how to correctly draw blood for those infected with HIV, how to do correct CD4 counts, et cetera. Talking to people like her and talking to many of the rest of you, your enthusiasm, your excitement, your spirit, your generosity of purpose, it reminds all of us all over again how important a university community is like this, and particularly one though that based here in the United States and here on Long Island is open to the world and open to the challenges of the world and preparing all of you to go off and deal with them and solve them and grapple with them over the course of your lives. It's just a very exhilarating experience, and I'm delighted to be a part of it. With that, let us turn over to our first presentation this morning. We're going to hear from a number of our panelists. I'll introduce them in sequence, but let me introduce the first of them, already probably known very well to you, and that is your university president, Samuel Stanley, MD. President Stanley received his MD from Harvard Medical School, as you will know. Prior to becoming president of Stony Brook, he was vice chancellor for research with Washington University in St. Louis and the director of the Midwest Regional Center of Excellence in Biodefense and Emerging Infectious Diseases. He was also a professor in the departments of medicine and molecular microbiology at Washington University. His years of research focused on understanding the molecular basis for pathogenesis and markers for genetic susceptibility, to disease. And I'm delighted to welcome to the podium now President Stanley.
Well, thank you so much, Susan. That was really a fantastic introduction, and you really set the stage, I think, for what we want to do today, and I greatly appreciate it. And, you know, one of the quirks of the program is no one actually had a chance to really suitably introduce Susan, I think, but we're incredibly privileged that Susan Dentzer, who is editor-in-chief in Health Affairs, as she said, as well as a frequent appearer on PBS, on the McNeil-Lehrer NewsHour, has really someone who's, I think, helps not only create information, rather create excitement and energy around this area, but also brings really expertise. And that often is lacking when we look to the news today, people who really are informed and really knowledgeable. And I think she demonstrated today why it's so important to have people in the media who really understand issues and can really communicate. So Susan, thank you again for being here. Join me in thanking you. So when we, There's seats in front, by the way, for those in back. I hate to see people standing throughout this, so if people feel the need to move down, please do, because we really do have a number of seats in front, and you won't disturb me one whit. As I made arrangements for this inauguration week or inauguration marathon, as I've called it as well, one of the things I thought was very important was to include something that told you a little bit about me and my interests. And so I've spent a lot of time kind of learning about the university. It's been incredibly valuable. But I thought it might be worthwhile to talk a little bit about something that's been a lifelong interest of mine, but with a couple of goals in mind. One was to, maybe do a little preaching or proselytizing about what I think is the importance of global health. And from what I've seen today, I really have an audience that probably recognizes much of that already. But the second, I think, and this is why I brought in such a distinguished group of panelists, was to think a little bit about what should be the role of Stony Brook. What should our role be in dealing with the issues around international health? How do we differentiate what we should be doing with the programs that the government sets up? What are the roles of the non-government organizations, such as the Gates Foundation? And to really try and better understand kind of where is our niche in this, and how can we be most effective in this problem. So I'm here today both to talk a little bit about what I see as some of the challenges around global health, and those will focus to some degree on infectious disease, of course, because that's my background, but also I think to try and learn today and think a little bit with you about what Stony Brook should be doing. And again, that's why that poster session I think was so valuable. So I have some slides, but I'll go through them pretty quickly. They're designed to just make a few points about why this is important, because just like you, I want to hear what our panelists have to say as well. So am I doing this? Next slide, or, okay. And it's told me which I need to push to move things forward here. Okay. Yeah. Okay. Okay, excellent. That'll do it. Thank you. So even though we're on Long Island, as we've heard, I don't think there really are very many islands anymore. Thomas Friedman has talked a lot about the flat world, or now the flat, hot, crowded world. And really, I think more than any time in our history, those kinds of barriers are gone. To the extent that we could rely on geography, essentially, to provide protection from us, either from disease or from culture or for anything, I think those days are long gone. And we talked about jet travel as removing both temporal and geographic barriers. That's been driven home by outbreaks of disease we've seen already. The increased population density around the world that really does make us more vulnerable for things like infectious disease. The effects of climate change and environmental stress are universal. So of course, none of us can escape wherever we are the effects of climate change and the effects of worsening the environment. So the fact that China will soon be the world's, or is going to become rapidly the world's largest consumer of coal, for example, has an impact on air quality in the United States and around the world. So all of these things we can't escape from. And I think as well, I think in some sense we're getting more connected with others through the internet. So it's, this is obviously not an unalloyed good. But I think the ability to kind of very rapidly see what's going on around the world and to recognize problems, again, has helped bring people closer and has stopped, and it's, I think, contributed to breaking down barriers. The other effect that may be less positive has been the effect of kind of Western culture as we disseminate it really around the world. And some of the things that may not have been so great to disseminate in terms of some of our dietary patterns and so on are also being disseminated around the world. And I think there are consequences to that also. And we are seeing, as we'll talk about, and we may within the panel come back to, the idea that while I'm going to focus today on infectious disease again, because that's driven a lot of the agenda when we've thought about international health, clearly, we can no longer limit it to that. And things like cardiovascular disease, diabetes, cancer, of course, are really global problems. And diseases related to things like smoking, for example, are global problems, and they're not just U.S. problems. And this is an area where we may be able to help from some of the things we've developed to give back to countries, some mechanisms we've had that have been useful. But we may also need to learn a lot about from their countries as well about things we may be able to do things better. So why should we care about global health and global health research? I think there's a number of reasons. One, I think there's truly a national security issue, and national security in a very broad sense of the susceptibility of the United States to devastating epidemics, as well as how it's certainly in our benefit to be seen as an exporter of things of health rather than other things like arms, for example, that we can export. In addition, I think the notion of the concept of how people view the United States. Are we viewed as a positive force worldwide, one that is actually contributing to countries? I think that's very important. And the other thing I'll talk about in security is the notion of stable governments. Health is key to the stability of governments, and I think a healthy country, I think, tends to be a more stable country, and I think, again, pursuing health around the world is very important. I'll also talk about the economics of this. Why is it important from an economic standpoint? So, that we do this. I'll talk about the fact that I think it's actually beneficial for research that we become involved globally. I'll talk about the fact that, as usual, I think young people are ahead of us, and so I think they're already foraging out, and I think it's up, for us older folks to kind of follow. And then I'll talk at the end about the moral imperative, and I'll try and do that all in about the next 8 minutes or so. So biosecurity, I focus this on infectious disease, but I'll just point out something that everybody knows, which is infectious disease know no borders. As we continue, as Homo sapiens continues to expand across the world, we're now coming into areas we've never been in before. When we do that, we encounter diseases we've never seen before. Ebola and Marburg were great examples of that. There's others that are forthcoming. And of course, microbes are evolution in motion. So earlier, as part of my inauguration week, I was part of a panel on evolution. And of course, evolution for an infectious disease doctor is really easy because it's right in front of us all the time. Bacteria and viruses evolve constantly, they change, and therefore become a new form of threat all the time. That evolution can lead to resistance to antibiotics or antivirals. We know that happens. It also can lead to an expanded host range where they now can infect a host they couldn't infect before, and sometimes, of course, that host is a human. So this is really evolution in motion, and we're always going to be at threat. And this has been characterized as an arms race, essentially, that the bacteria and viruses continue to evolve. We have to evolve responses to them. The question is, who's ultimately going to win this arms race? And then I think global research and particularly cooperation are absolutely critical to detecting these new kind of pathogens and actually dealing with threats that come our way. And to do all these things, I think we have to restore things that have suffered really over the past decade. And as Susan said, we've made a lot of progress in these areas. And so some of this is things where progress has been made. But I still think an international public health infrastructure is absolutely relevant to the United States. We need to find incentives for companies to produce vaccines. They have to have incentives in some cases to do them. And I think we have to have support for basic and applied research on these biological threats. And three of the panelists, three of us today, are members of the Paul Rogers Society of Research America, which is essentially established to promote global research, global health research. And Paul Rogers was a congressman, essentially, who was a tireless advocate for global health. And the purpose of the Paul Rogers Society is actually to get the message out about the importance of global health to the community. And Karen Gorleski is here today on behalf of Research America. And Pierce Gardner is also a member of this group as well. So we really have a stake in this as we move forward. So as I mentioned, infectious disease know no borders. I just want to give two examples. One, these spots on this child are actually poxes, and this is an example of monkeypox. This was a disease that had only been found in Africa, appeared in the United States, imported on the back of a giant Gambian rat, essentially, that was brought in the United States as a pet, led to an outbreak in the Midwest, and led to the first cases, as I said, of pox viruses in the U.S. It had been a devastating disease in Africa, much more severe in Africa. Through research that was done actually at the Biodefense Center I used to head, we actually discovered some of the reasons why the outbreak in the U.S. wasn't associated with case fatalities or severe morbidities. So this example, I think, is for two things. One, it points out, again, that we are susceptible to diseases from anywhere. Two, it also points out that the kind of scientific research that we can do can help prepare us for these kinds of things and help us understand the threat and deal with it more rapidly. And then, of course, SARS is something we may be slipping from mind now because it was more than 6 years ago now, or 7 years ago, but more than 8,000 cases, 774 deaths. Really exploded internationally. It was a classic example where one could have a disease that had an outbreak in China and that was in Toronto in the snap of the fingers and was there and really was able to spread globally very rapidly. That was a wonderful example of how research responded to a disease. Within 3 months, the virus had been identified, it had been sequenced, the natural host identified, diagnostic tests based on viral sequence developed, Koch's postulates had been fulfilled for it. And understanding the disease already led to some preventive measures, and of course, no further significant outbreaks have occurred from that disease. But that kind of thing, again, it points out the fact this is an example of a coronavirus that probably changed its host specificity, was able to jump to a new host, caused significant damage, ultimately was contained, and part of that was a global response in which the U.S. played a very important role. And there's been a number of new threats. Chikungunya caused 260,000 cases of a really severe viral disease in the island of Reunion. 4 deaths in South Africa a year and a half ago from an unknown virus, which we now know is an arenavirus. And right here, methicillin-resistant staphylococcus in the United States and the world requires expensive and more toxic antibiotics. We're working very hard right now, the folks who are in this hospital, to try and prevent spread of this disease because our antibiotics are becoming increasingly less effective. But this is the kind of threat we have to deal with. And then, of course, H1N1 influenza, the most recent threat, I think, from influenza, which is an ever-present danger. And again, a reason why we're all in this together. So, as I said, I think we need continued research into this field. I think this is one area where I'll speak out and say universities, I think, play an important role in being involved in research in this area. I think we need collaborations on new diagnostics. And again, I think the U.S. Has to be a leader in this area. And I'm going to skip all of these in the interest of time and talk about, again, what are some of the other benefits, I think, from addressing these. And so I think there's a number of things, as I said before. Epidemics and endemic diseases destabilize countries. I think they lead to increased potential for conflict. This is recognized by the State Department, essentially, and helped lead for some of the investments in HIV, for example, came from the realization that these were actually destabilizing factors in a number of countries. As I said before, I think it's potentially far more effective to export health than propaganda or arms. It's a wonderful view, as we saw today in the posters, when we see U.S. healthcare workers helping to train healthcare workers in other countries for the future. That's the kind of sound bites, I think, that ultimately are much more effective than some of the other things that we see sometimes. And I think, again, from an enlightened self-interest point of view, I think the U.S. really needs to maintain its lead in innovation and knowledge economy. As I've said before, if the U.S. is really going to stay a world economic leader, then we have to be a leader in innovation. And these are problems that affect everyone, and these are problems that are going to require solutions. And if those solutions come from the U.S., that type of lead, I think, is incredibly important as we move forward. And there are emerging markets in Africa and Asia for improved healthcare delivery and products. The middle classes in places like India and China are going to become important sources economically. And again, I think we need to be at the forefront of developing things that are going to improve health in those areas. And finally, I think from a research point of view, there's a tremendous value of doing studies in multiple sites. So the U.S. is a relatively genetically diverse population, but there's a lot of value, I think, to learning how things work and how things how drugs or other things function in different parts of the world. Again, because of the global market issue, but also because it'll help us understand genetic variabilities, which may be important as we plan future drugs. So I think there's other important reasons to do this. And I think, again, we need to follow our students in this area. So one of the things I became very impressed at WashU when I was there was how much the students were driving this agenda. The students were more and more interested in international health opportunities. They were the ones really clamoring for more courses, for more opportunities to go abroad. They get it in terms of how important it is to think globally, and I think we need to follow. And finally, I'll conclude by talking about a moral imperative and the burden of disease. And so Susan alluded to this. We've made a lot of progress, but there are still many things we have to deal with. 247 million malaria cases still, about 3.3 billion people at risk in 2006, and nearly 1 million deaths, and most of those are in children under 5 years. HIV/AIDS, 33 million adults with HIV in 2007, 2.7 million new infections, so new infections occurring at that time, and 2 million deaths from AIDS. And of course, it's not just the infectious disease, depression, something we don't always talk about. 120 million cases worldwide, #1 cause of morbidity around the world, days of potential life loss. Diabetes, 171 million cases in 2000 to 366 million estimated in 2030. One of the neat things we're doing at Stony Brook is really trying to better understand the origins of man, but there's, of course, a number of people who've been working on this. And, of course, one of the amazing findings that we're all aware of is the fact that we can probably trace our ancestry back to a mere 60,000 years ago in terms of looking at a common ancestor for all of us. So I think that drives home the fact that we really are family. Really 60,000 years ago, evolutionary geographic timescale is absolutely a drop in the bucket. We are all really closely related, and I think we need to take that perspective that a life lost in Africa is no different than a life lost in New York. And so I think, outline, I think, what the important thoughts are. And my final thoughts will be, what should our role be in global health research and providing care? What are the roles of the other major players? And how do we coordinate our activities to really maximize the impact we're going to have in this important area? Thank you.
Thank you so much, and we're obviously off to an invigorating start. Let's move on now to our next speaker, and we're delighted to have with us Congressman Timothy Bishop. Tim Bishop represents New York's 1st Congressional District, which of course is here on the eastern end of Long Island. He's a lifelong Long Islander, proud of his record of hard work and effective constituent service. He focuses in protecting Long Island's middle-class families, but he has a number of other priorities in Congress, which include improving the economy, fighting for veterans, safeguarding the environment, and, of course, a topic you may have been reading about, reforming health care. He's going to speak this morning about the U.S. government's role in a number of arenas: basic biomedical research through the National Institutes of Health, the world's leading biomedical research institution, our role in public health, both domestically and globally through the Centers for Disease Control and Prevention, and so on. Join me in welcoming Congressman Bishop.
Well, good morning to all of you, and thank you for the opportunity to be with you. I have no slides. I'm also the one member of the panel that is not a member of the Paul Rogers Society. That probably will come as no surprise to any of you. But I am very pleased to be here, and I am particularly pleased to be a part of the celebration of the investiture of Dr. Stanley as the president of this wonderful university. And I am certain that all of you who work here know how lucky you are to work here, and I'm certainly all of you who study here know how lucky you are to have that opportunity. So I am proud to represent this university and proud to welcome Dr. Stanley to the 1st Congressional District. I wanted to just talk for a few minutes about the federal role in dealing with global health issues. It is a priority for the United States, and one of the ways the United States expresses its priorities is with commitment of dollars. Our commitment of support for global health activities has grown really quite significantly since 2001. In 2001, we spent about $1.8 billion a year. In 2009, we spent about $9 billion. And the president's budget request for fiscal 10 increases that number by a couple of $100 million. We expend these funds primarily through 3 broad programs. One is PEPFAR, which I know you're all familiar with. The second is USAID, and then the third are various programs administered by the Centers for Disease Control. And I thought I would talk a little bit about each of those 3 programs. PEPFAR was begun in 2003. Ultimately, it is President Obama's hope that approximately 70% of our global health activities will be focused on PEPFAR-related activities. PEPFAR basically is divided into 3 broad categories: prevention, treatment, and care. In prevention, we have reached an estimated 59 million people through our various community outreach programs. And by the way, you all know this, that the locus of this disease is in sub-Saharan Africa. About 2/3 of those who are infected are in sub-Saharan Africa, and so that is where we are focusing the lion's share of our activities. We support prevention of mother-to-child HIV transmission. We have done so far in approximately 16 million pregnancies. We have supported antiretroviral prophylaxis to approximately 1.2 million pregnant women, which has allowed approximately 240,000 infants to be born HIV-free. In terms of treatment, we have supported life-saving treatment for more than 2.1 million men, women, and children, and spread across approximately 15 countries. And we have increased the share of those receiving PEPFAR-supported treatment who are children from 3% in fiscal 2004 to approximately 8% now. And in care, the three key dimensions for care have been to care for orphans and vulnerable children, to care and support for people who are infected with or infected by HIV/AIDS, and then HIV counseling and testing. The allocation of the resources, approximately 30% is allocated in support of care activities, approximately 50% in support of treatment programs, and then the balance, approximately 20%, in terms of prevention. The second broad category of U.S. government involvement in global health initiatives is with USAID, which maintains 5 broad programs, and we spend about a little under $2.5 billion a year on those 5 programs. They are child survival and maternal health, vulnerable children, HIV/AIDS, other infectious diseases, and family planning and reproductive health. And then the third broad category is the Centers for Disease Control and Prevention, and there are a number of programs that run under the auspices of the CDC. There is the Global AIDS Program, there is the Global Malaria Program, the Global Tuberculosis Program, the Global Disease Detection Program, Pandemic and Avian Influenza Program, and then a global immunization program. So there's a great deal of activity that the federal government is engaged in, and President Obama has initiated an effort to coordinate, to provide better coordination of what we now do. One of the things that happens in Washington, I'm sure you all know this, and this is a phrase that is sort of a inside the Beltway phrase, but there's a lot of stovepiping. There are things that go forward and that stay within the parameters or the boundaries of their program, and there isn't as much cross-fertilization, there isn't as much sharing and cooperative efforts as there should be. And the President announced an initiative in May to provide a much greater coordination of all of the global health initiatives that the federal government undertakes. He wants to get our funding up for these programs, as I say, from an average right now of about $9 billion a year, upwards of $10 billion a year. That will be, frankly, tough to do in the fiscal climate that we find ourselves in, but it is a worthy goal and one that I hope the administration and the Congress can work cooperatively to achieve. I want to just make one other point, and that is the point that Dr. Stanley made about the role of the United States in this effort. And there are several imperatives, but one of them is changing the image of the United States. And I don't want this to be a political comment, but I think we all recognize that we are emerging from a period in which our global image was tarnished somewhat. And one of the goals of the Obama presidency and one of the goals of the Congress is to see to it that we reclaim our rightful role in the world. And one of the ways that we are going to do that is through the implementation or the deployment of so-called soft power, as opposed to the kind of power that we have wielded, at least in the recent past. And a global health set of activities is an example of the kind of soft power that this nation can employ and achieve multiple goals, not the least of which is improving the quality of life, prolonging life, and so on, but is also about how we are viewed in the world and how we use a perception of this nation in the world as a means of dealing with the issues that we deal with respect to national security, with respect to terrorism, and so on. As I say, I think it will be difficult for the United States to significantly increase its investment in these areas, given all of the demands on our national treasury, and frankly, given how overextended that national treasury already is. But it is encouraging to see the President take the position that he's taken, and I do believe that there will be broad bipartisan support for what he wishes to do. For example, as I say, PEPFAR was begun in 2003. That's when I first entered the Congress in 2003. And I think it's fair to say that our Congress is one that is bitterly divided. About the only thing we can agree on is when we have to name a post office for someone. But PEPFAR was a program that passed with great bipartisan support. And in fact, the push for additional resources beyond what the president requested was a push that was led by both Republicans and Democrats. I hope that serves as a model for what the government can do in the future. So I thank you, and I'm pleased to be here. Thank you.
Thank you so much, Congressman. We will now hear from James Kazura, who's a professor of medicine and international health and director of the Center for Global Health and Diseases at the Case School of Medicine at Case Western Reserve University. His work focuses on advancing fundamental knowledge of the mechanisms underlying susceptibility to infection and the pathogenesis of disease due to malaria and chronic worm infections, which, as we know, are endemic in tropical areas of the world. His goal is to develop preventative and interventional strategies that are culturally appropriate to those regions and cost-effective. And he's also a longstanding colleague of your president, Sam Stanley's. Join me in welcoming Dr. Kazura.
Thank you for the introduction, Susan, and it's a true privilege and honor to be here at this inauguration of Sam Stanley. And what I'd like to do in the next 5 to 6 minutes is really address 3 fundamental issues, focusing primarily on the university, since that's really where I've been at most of my adult life. First of all, why do global health at a university or at a school of medicine or outside the walls of a school of medicine? Secondly, how should it be done, and is there a best fit model for this? And thirdly, what are, at least from my perspective, what are the real challenges to executing a successful global health program at a university? And just so you understand where I'm coming from, I'm a physician, I'm a physician scientist, and when I went to medical school, I didn't really think about doing global health. We didn't call it at that time in the 60s. We were more caught up in Vietnam and the war, and actually people of my generation and earlier, a lot of the people who were physicians and did research actually got into this area through their experience in the military in Vietnam. So why do global health? I think that's really been adequately covered, to tell you the truth. So why at a university? Well, first of all, I think a university really has the broad array of talent and interest to make the field go forward. And what do I mean by that? First of all, most of these people in this room are biomedically oriented. But truly, global health, the way that we've been thinking about it today, not only involves the biomedical sciences, it involves behavioral issues, social science issues, policy issues, and implementation issues. So one can actually interact with engineers or with social scientists who could actually make significant contributions. Because we're all in this, most of in this room are looking at the elephant of global health from the perspective of physical aspects of healthcare or improving healthcare delivery, but there's a lot of other issues relating to how can we afford it, how do we interact with government programs and things of that nature. So it's really a crucible of creativity from that perspective. The second thing that's really important is we're at a university where one of our major issues, of course, is to deliver the next generation of people who are going to work on global health. And just by what we've been hearing this morning, listening to some of the student presentations, there is really an increasing demand. I must say, I'm 62 years old now, and I've never witnessed, at least at my own university and other universities that I've visited, a demand for this, not only in schools of medicine, schools of nursing, schools of dental medicine, but also even at the undergraduate level. So we kind of owe it to this really strong impulse of humanitarianism that many people who come at this from different perspectives really all share. And I think it's one common thing about the Paul Rogers Society in particular that distinguishes people who are in the biomedical sciences who are focused on global health versus other more local type issues. So How should it be done? Well, there's not probably one best fit model. The model that I've experienced is, first of all, is to emulate some of the things that I've been privileged to experience in my own career. First of all, I got into this area when I was a medical house officer, and Adel Mahmoud was a rising young star doing research in all places in East Africa on a disease that I think we probably spent 2 minutes on it when I was in medical school on schistosomiasis. But he was a very dynamic individual, and he and others in the department where I was working had the foresight to actually take young people and expose them to this in East Africa. I'd really never traveled outside the United States until after I was an intern. So we had the opportunity to spend 3 months in Kenya working on a schistosomiasis research project. Part of it was actually doing physical exams out in the field. Secondly, was actually doing laboratory-based immunology work, which was in the dark ages of immunology. This is before there was such a thing as even as a monoclonal antibody or a cDNA library. It's pretty rudimentary stuff now, but you had to really make your own reagents. And actually, it wasn't just the science and that exposure, it was the milieu that one was in. I would interact with people from other universities outside the U.S. who were really oriented towards ecology, oriented towards healthcare delivery. And even though I was not an expert in that, it gave me the opportunity to really become intellectually fulfilled. And I think that's one of the things that turns on many people in global health. It's an opportunity to really bring together a lot of different research disciplines, as well as the service thing. You can there's an old New Yorker cartoon where there's a million starfish on a beach that have been washed up. And there's this person out there taking one starfish at a time, throwing it back in the water. And someone says, why are you bothering to do this? It's hopeless. She said, it's not hopeless for the one that I just threw back in the water. So we can, in global health, encompass all those different impulses that we all share to varying degrees, saving the individual life through service or humanitarian disasters, as well as looking at broader population health issues, as well as looking at policy issues to engage stakeholders in this. And this is where I think a university is a wonderful environment where that can be accomplished to a certain extent. So what are the challenges to it? First of all, academics, in particular for the faculty, is built on individual success. That has been the model in the past. What we just talked about bridges a lot of different gaps. It requires teamwork. It isn't one versus another. So particularly in the area of academic accomplishment, I think our committees, and I'm speaking for many of us in this room, have to get over this idea that you identify an enzyme, you clone the enzyme, you determine its function, and that's essentially all you do. You need to do that kind of thing, but what we're talking about in global health is much more team-related type efforts. And that's really antithetical to the way that many universities within the School of Medicine versus the undergraduate school are on different kind of schedules, have different goals, et cetera. This is something that a structural issue that has to be kind of addressed. My personal bias is that we have to do it by actually making actual academic units called global health, where one can actually get primary appointments and can actually develop a career trajectory in global health per se. I may be wrong about that, and it may work in some situations versus another. Another one is, how do you pay for this? Okay, so my primary funding comes from the National Institutes of Health, and right now at the National Institutes of Allergy and Infectious Diseases, for R01 grants, which is the primary way that investigator-initiated ideas get funded, is at the 6th percentile. In the bad old days of 1990 and 91, it was at the 9th or 10th percentile. I never thought I would be the 6th percentile. So I'm at kind of the end or the plateau phase of my career, but for getting young people into this who want to do research on it, it's an uphill battle because they can see this is a tough road to go. Hopefully the economy will improve. We've heard that the director of NIH and some of the things that Congress was talking about, there's more attention to global health. This is the positive things, but that's another significant structural issue. So in the end, I think we'd all agree this is an essential thing that we can do, and I think a university in this country, as well as universities outside this country, have a unique role to play in this effort. Thank you very much.
And now we'll hear from Adel Mahmoud, whom you just heard Dr. Kazura speak about. Adel is the professor at the Woodrow Wilson School of Public and International Affairs, focusing on disease control in the developing world, but he previously was president of Merck Vaccines and made an enormous contribution. Many of those children I spoke about who are alive today around the world and have grown into adulthood are alive today because of the work that Adel and his colleagues did at Merck. He's senior molecular biologist now at Princeton. His research and teaching focus on medical and policy issues related to microbial threats of the sort that Dr. Stanley described earlier, including pandemic influenza. He fields studies in several endemic areas and developed the scientific basis of strategies to control helminthic infections, as we were hearing a moment ago from Dr. Kazura, and those practices have been adopted globally. Join me in welcoming Dr. Adel Mahmoud.
Thank you very much. It's a pleasure and honor to participate in the inauguration of your new president, whom I am a very, very fond and admirer for many years, not only because of his science, but also because of his personality. This is a guy that is full of energy, full of commitment, and knows how to lead. And it's really fantastic that you managed to recruit him. Great job. Great job. It's very, very good to participate in a session on global health. But I just want to remind you, this country actually contributed a lot to global health. I mean, we would not have had not only one, but 2 polio vaccines, except for scientists in this country. We would not have had the global eradication of smallpox, except for scientists from this country who went to Geneva and led the global effort. But we didn't come from the moon. We actually are a product of the scientific knowledge of the world. Approximately 150 years ago, our medical schools were schools for practitioners. It never had a scientific backbone. I mean, it was the Flexner's report who said we have to have education in science before we get to educate in medicine. Years ago, the dean of Harvard Medical School, these guys a little bit north of here, wanted to institutionalize a written exam for the graduates of Harvard Medical School. And the chairman of surgery went to him and said, "What do you think of yourself? Half of my students don't know how to write. They will not be able to answer a written exam." Where is the science that came to us? It was the European science. The German schools, the French schools, and the British schools are the 3 fundamental schools that built our scientific knowledge. This is not to say we didn't contribute, but it's just to absolutely make the point. We are a product of what the globe put together, what this world put together as the best science. And we have to give back. We have to articulate a sustainable political and scientific effort for the whole world. I admire all the efforts that are going on. I admire all the funding that has increased over the years. But it cannot be few vertical programs sitting next to each other. The world needs the United States leadership in development, in social science, in economics, in scientific pursuits, just as much as in political pursuits. And we are the model for the world. I mean, whether we like it or not, this is our destiny, to lead. And we're coming up of several years of being away, absent. Where is America? And today, America has to get itself back. And the only way to get ourselves back is to sustain a presence in health. But as Jim Kazura, as President Stanley, as our congressman indicated, health is a comprehensive approach to human development. It is not a vaccine or an antibiotic or a treatment. It's a comprehensive package of many, many aspects. And unless we appreciate that, most of our progress in lifespan extension in this country happened in the first 50 years of the 20th century with very little technical solutions. Very little. There were no vaccines and there were no antibiotics. And we increased the mean lifespan in this country from an average of 44 to an average of 65 by 1950, in spite of the absence of these magic technical bullets. And if we go and sell the world today that there are magic technical bullets, that if they don't pursue it, they are not going to progress, we're kidding ourselves and kidding the world. We developed ourselves by a comprehensive approach, and we have to help the world develop themselves by a comprehensive approach. And there is no better country to do that except the United States because of our history. I love our friends, the economists. They think that they discovered the phenomenon of globalization. Actually, the phenomenon of globalization were discovered by the microbes thousands of years ago. And we need to just educate them. I mean, it's about time we educate them. There is no better leadership for the new future except you guys. Not the old guys in the audience, but the young guys in the audience. We have done most of the work we could have done, and we didn't achieve what needs to be achieved. So basically, it's you. Thank you very much.
Great. Well, we've heard four extremely important sets of comments that I think will set the stage for a terrific discussion going forward this morning. First, we heard from Dr. Stanley that we do have a moral and strategic imperative. The strategic imperative is that the U.S. can exercise its soft power and show the world that we can do a good job of exporting health, and guess what? We can do an even better job and make an even greater contribution in that arena than in exporting arms. And we have a moral imperative, he said, to do this. A life being lost in Africa is no different than a life being lost here in the United States. We heard from Congressman Bishop about the enormous injection of funding into, for example, PEPFAR, the contributions thereof, 240,000 infants born HIV-free because of the PMTCT programs put in place under PEPFAR alone. But he also talked about some of the challenges we face going forward, the fact that many of these programs, such as Adel mentioned the word vertical programs, the stovepipe programs, I know Gail Smith in the administration often refers to these as our cylinders of excellence. Basically, our HIV/AIDS programs, our maternal and child health programs, other programs that are very good in their own right but don't necessarily coordinate to provide a comprehensive approach. He talked about the difficulty of reaching the administration's goals in global health of up to $10 billion a year, given our straitened economic circumstances and, frankly, other pressures on the federal budget, most particularly of which will include domestic health care reform. And he talked about the political realities in Congress, the Congress being so bitterly divided it can barely agree on what the day of the week it is, let alone some of these major issues like health care reform or investment in global health. We heard from Dr. Kazura that the global health is really the perfect topic to tackle at a university, given what a university can bring to bear, both in the realm of biomedical research, in the realm of implementation sciences, and everything in between. And particularly in an era when we know that team science, that is to say people specializing in different branches of this, or different body parts, I should say, of this global health element will be very important to providing the comprehensive solutions that Adel talked about. He talked, Dr. Kazura also, though, raised the challenges that we face just in terms of the flattened National Institutes of Health budget. And it being another feature where we would like to see much more investment overall in the NIH budget, but particularly also in global health, and how difficult that will be in the current economic environment and in the few years we can see down the line coming forward. And then we heard, just as you did a moment ago from Adel, basically the enormous contribution of other countries to global health science and to science in particular, and how much the United States was a beneficiary of that investment and how much now we need to give back. But again, he's emphasized that we shouldn't just do this through these cylinders of excellence, these vertical programs, but there really is a need for a comprehensive approach to make health truly an ingredient in human development around the world. Setting, I think, the challenge for all of us to think about the ways we might best knit together these various initiatives, continue to make the investment, continue to rise to meet the challenges that others described, and advance not only the health but the well-being of most of the world. So with that, I think, as I say, we've got a terrific platform to move forward upon and to talk about some of the challenges that remain. Let me start by asking, most of the people in this room are here because you agree that a life lost in Africa, or for that matter in Sri Lanka, or for that matter in China, or any place else around the world, not to mention the South Bronx, is no different from a life lost anywhere else in the United States. But how much do we believe we need to continue to persuade not only our fellow Americans that that is the case, but others around the world, such that we are willing to make the investments we need to make in global health? And Dr. Stanley, I want to throw that one first to you. What can you do as a university leader to continue to send this message and gain the kind of support that will be necessary to deal with some of the obstacles that others have laid out?
So this is one area where I think Research America has actually been helpful in terms of polling the American public to try and understand what their attitude is. And in general, I think the finding has been quite clear that the majority of Americans recognize this kind of moral imperative we're talking about, the fact that investing in international health is incredibly important to the health and security of the United States. Having said that, I think there still is a challenge, I think, in getting across the message of how much we've done already and yet how much there still needs to be done. And I think, again, this is a tough sell at this moment in time. I think that as we start to look at the kind of economic challenges we're facing, it becomes more and more difficult. And to return to the point I made later and I made earlier about, I think, again, there are elements of economic development even within this, that the United States, if we're going to maintain a leadership in innovation, which I think is absolutely important, then I think it becomes, if we're going to maintain a leadership in innovation, then I think it becomes absolutely critical that we take the lead in this arena. And I think that, as I said before, I think as we look forward towards the future, and I think all of us anticipate a future where there will be a rise across the globe, that there will become a larger middle class, essentially. And I think being at the forefront of health, really helping push that forward, will really make a positive difference. So I think there are important reasons why we need to make this argument. I think it's both a humanitarian argument. I think the moral imperative carries some weight, but I think appealing to enlightened self-interest also is very important. But I think, as I said, I think most Americans, I think, are actually in agreement.
Let me just mention that we may be having some feedback problems because people have BlackBerries or other devices on. So if you do have one on, please take a moment to turn it off, if you would, just to reduce that level of interference. I'll give you all a few seconds to confess that your BlackBerry is on and pull it out and turn it off. Congressman Bishop, I want to turn to you now because you mentioned the difficult political divisions in Washington now, but you also mentioned that there had been a lot of bipartisan support, for example, behind PEPFAR, as well as has been the case behind other global health initiatives. What do you think the future is in terms of forging a more united approach among the parties now as we go forward on some of these issues? It is always the case that whoever is the president, when he or she, I should say, hopefully, advances a global health initiative, people respond to it in a kind of a partisan way. Certainly, President Bush found this when he first initially proposed PEPFAR. He then, fortunately, many people came around and supported it. It is likely to be the same case this time around with President Obama proposing the expansion of funding under his global health initiative. He may get some resistance to that on the partisan side as well. How do we move forward?
Well, I think it's very difficult. In part, the climate is much different now than it was in 2003. And there are a lot of things that are at play here that make the argument for an additional investment in global health that much more difficult to pull off. I mean, just look at some of the factors. Number one, we have an economy that is in deep distress. 7 million people have lost their jobs over the last 14 months. Mean income has actually gone down. People have lost, collectively, we have lost billions. People have lost billions in terms of their retirement. We have spent hundreds of billions of dollars to resurrect our financial services sector. Approximately 7,000 families a day are foreclosed out of their homes. So we have enormously difficult problems domestically. We also have an environment in terms of our global posture that has encouraged a sort of provincialism. And we are spending $3 billion a week in Afghanistan and Iraq. We are doing so at a time where we have enormous needs here. So I think the case to be made, which is one that can be made on any number of grounds, is made all the more difficult by our recent history and by our current difficulties. And again, overlaying all of this is we spend about $1.4 trillion a year more than we actually take in. We have our own domestic health program, Medicare, which everyone agrees cannot be sustained at its current rate. We're spending about $500 billion a year on Medicare, and everyone agrees that we can't sustain that. So the challenge will be, how do we balance what is our global obligation, one that we have long recognized is one for us to take up, and in fact we have taken up. How do we balance that against the fiscal imperatives, and how do we balance that against the political realities where the political reality, the winds are blowing basically to have us pull in and have us spend more of our resources on improving quality of life in this country in any number of ways, not just in terms of health, but economically and socially and so on. So I'm not sure I'm answering the question. I think I am defining the context within which some really, really difficult decisions are going to have to be made.
Do you want to take a stab at giving us some insight into how our domestic health reform may play out? Or is that even a harder question to solve than?
I'm happy to discuss healthcare reform. I would feel much more comfortable if you were yelling at me and if you were telling me I was a liar and perhaps
This group spends most of its time on this planet, right?
bringing in homemade coffins on which you've written Obamacare, something like that. That would make me feel more comfortable. Look, we're going to do something. We're going to pass healthcare. We're going to pass some form of reform. I think that we will see much greater regulation of insurance companies. I think we will impose on them nationally the kinds of requirements that in many cases are already in place here in New York State. I think we will significantly decrease the number of those who are uninsured. I think we will do something to see to it that those who are uninsured receive some form of subsidy to be able to afford insurance. The key questions that remain unanswered, it seems to me. One, the most contentious issue is, will we have a public option? My own view is that we will wind up with some form of public option, whether it is the Olympia Snow trigger idea, whether it is the Chuck Schumer or Tom Carper allow states to opt out of a public option. But we will have something, because I think there is some broad recognition that unless there is a structural imposition, if you will, of competition, we're going to have a very hard time having the insurance companies behave in the way that I think most reasonable people would like them to behave. And then the most difficult issue, and it's the one that all of the bills sort of take steps towards but don't really accomplish, is how do you, our inside the beltway jargon is how do you bend the curve? But English, how do you reduce the rate at which healthcare costs are increasing? And there are lots of proposals, whether it be bundling, whether it be accountable care organizations, whether it be increased use of comparative effectiveness research, which is rooted in increased use of health IT. There are lots of ideas out there, but the whole goal here, yes, we want to insure more people. Yes, we want to improve health care for this nation, the richest, most technologically advanced nation in the world. But the whole goal is to see to it that it remains affordable. I'll say one last thing if I'm going on too long. One last thing. This has been portrayed as a means by which we are going to eviscerate Medicare. Quite the contrary. This is how we're trying to save Medicare. As I said a moment ago, Medicare is unsustainable in its current form. So that leaves us with three choices. One is raise taxes to cover the increased expenses. No one wants to do that. The second is to reduce the coverage that Medicare provides. No one wants to do that. So the third option is to see to it that what we do provide costs less, or at least increases at a less precipitous or a somewhat lower pace. And that's what healthcare reform is all about. Healthcare reform is about reducing the rate at which expenses increase so that we can continue to provide people with coverage. Whether we'll get to that, at least in this round, I think is very problematic. I went on too long, I'm sorry.
No, it's a topic one cannot exhaust, and your colleagues are showing that that's the case in Congress now, so thank you for that. Dr. Kazura, I want to come back to the challenge you mentioned, and that has indirectly been alluded to at others, which is how do we keep the biomedical research engine going forward in this country amid the fiscal concerns and other factors that have just been mentioned. Research America is a proponent now that we increase the NIH budget upwards to $40 billion. This would be a big increase in actual terms compared to what is currently the case, but actually compared to what it would have been if we had kept the doubling going forward, it's not that big a deal. But yet we have a situation today where the average age, I think, of people getting their first 401 grant is about 41. Many of you are probably potentially in that pool. How are we going to come to grips with growing the NIH budget, continuing to meet the demands that we think we need to meet, not just on the domestic front, but the international front, amid all of these various challenges that have been enumerated?
Well, aside from a turnaround in the economy, I think one has to be realistic of what's going to happen over the short term. But I think the universities in particular have a special responsibility in this respect, because in many ways the growth of many universities, especially the research universities in this country, has really been a benefit of the NIH through the indirect cost mechanism. So the argument or the points that I often make with the dean when I'm trying to recruit somebody and want to start a package of $500,000 or $1 million or whatever it is. This is an investment in our future. We have to be poised for the ultimate eventuality, which I think we all will believe in, that the economy will recover to a certain degree. We all agree, I think, that the United States and the Congress and that the National Institutes of Health is perhaps one of the crowning jewels in this country's recent history, in the post-World War II history, which is, I think, in large part responsible for what Adel was referring to, is that it is true that European science was really formed the bedrock of what allowed advances in medical research in this country. But this country, if you compare the national health system in the United Kingdom, for example, and I'm not from Britain, but the Wellcome Trust is a great thing, but the National Health Service there, in terms of getting grants, is really pretty miserable. It's been worse. It's worse than the NIH is right now for the last 10 to 20 years, as far as I'm aware. So I think that to keep the pipeline going, we're going to have to take more money out of university endowments and use more of our operating funds to support people through these rough times, and to maybe even perhaps change some of the rules that we have in terms of when the tenure clock and things of that nature. And that's up to universities to do that. They can do that with the support of their board of trustees.
When you say changing the tenure clock, what do you mean?
Well, so for example, I don't know what it is here, but at my institution, at the School of Medicine, you have to get tenure by your 8th year. And that means, whatever tenure means in terms of finances, at least it's psychological. And tenure is one of those things that if you don't have it, it's bad. If you do have it, you don't know exactly what it means, but it shows that the university has some confidence that you will continue to be a productive citizen. So it does have, it may have, like this is a state school, it may actually have specific financial commitments associated with it, whereas at my university it probably does legally, but at least the threat of it does. It prevents the department chair from telling you don't have a job in the next year or so. So it's the way that the system works in terms of rewarding people who are steadily productive and keeping them at an institution.
You're saying universities may need to let the clock run a bit longer.
And we've certainly done that. This is one way we've actually allowed young families, particularly young women, to start having children at a reasonable time in their life. And so you can reset the tenure clock for that type of thing. I think universities have kind of, in many of the professions, at least in medical schools, they've really done a lot to kind of work on that type of thing. It applies to paternity leave as well, if that's the way the family decides to. There's different models some people have. These are crazy models, but if you have a husband and wife, they can split a tenure position. That's always hard by saying, well, who is the person who really made the accomplishments and stuff, but there's various ways of doing this kind of thing that various universities have experimented with, including my own.
All right, so we can expect some innovation ahead. Adel, I'm going to take the opportunity to start introducing some questions from the audience. We have another room where people have been writing down some questions, and we will be shortly opening it up to questions here in this room as well. This question came in, and it asks, with the success of programs such as the elimination of polio and smallpox, which you mentioned, and I guess we're not at the elimination of polio, but close and hopefully closer as time goes on, how can it be said that stovepiped or vertical programs are not effective in dealing with issues of global health?
Somebody wants to get me into trouble. Yeah.
That's a good question.
As a matter of fact, the vertical program works only in one example, and that's the smallpox. And as much as we hope for something to happen with polio, it really doesn't happen. It hasn't happened. The announcement was we will eradicate polio in 2000. It was extended 2002 to 2005, and now the WHO basically stopped talking about when it is going to be eradicated. Okay, so that's reality, because it is costing $450 million a year, and I'm not sure that there is an end game because of two reasons. And now I'm going to put my scientific hat. The idea that one species, Homo sapiens, can eradicate another species whether it's a virus or a bacterium or whatever, is an absolutely foreign idea. Who do you think yourself are? I mean, from the point of view of the ecology and the evolutionary biology, there are more of them than of us. There are more bacteria and viruses and protozoa and helminths than more of us. Our relationship developed in most circumstances to be either a commensal or a symbiotic relationship, and only in a minority of cases it is a pathological relationship. And if you look at the function of the human microbiota, we think we are pure. What purity? 8% of our genome is of retroviral element. Each one of us has about 2 or 3 pounds of bacteria in our gut. If we get rid of it, we get sick. So that whole concept, we're going to go after eradication, is absolutely a bankrupt concept. It worked in smallpox, and I'm absolutely happy that it worked. But it is 2009. Has anybody stopped polio vaccination in this country? We have not seen a paralytic polio case since the early 80s or late 70s. Why we have not stopped the vaccination? This is what everybody tries to sell you, that the moment you eradicate, you're going to stop vaccination, and look at the money you're going to save. We have not stopped vaccination. We have not stopped vaccination for polio, for measles, for mumps. There is an outbreak of mumps next door to you. Why? Because the vaccination rate is decreasing a little bit. So the relationship between us and microbes is a much more complicated than the simplicity of eradication, in spite of all those who fancy the idea. And I have to be careful, don't spread the word that I said that.
As you see, Adel is a man of few opinions in this field.
Susan, can I just add
Please.
one thing to that? Just to return to the point that Jim made previously. One of the challenges, of course, with polio has been a political and social issue in terms of disruption of some of the countries where polio was targeted for eradication, making it difficult to actually establish vaccine programs. I think it gets back to what Jim said, that this is an issue actually that has, resonates with us in terms of policy, in terms of universities thinking about issues about coexistence, political science, how you deal with conflict. There are also engineering issues involved in these kinds of eradication programs, things like cold chain and so on. So there are ways in which I think we could help, but I would never argue with Adel. I know much better than that. It is very challenging, but I would still think, do you really think that we won't get rid of polio? I'd have to ask, because I'm kind of counting on that as a future outcome. And I think, as I say, at least a lot of ways right now have not been perhaps related so much to that, to the issue of the efficacy of the vaccine, but the issues surrounding the ability to deliver it. And that's a problem. And I think, again, we see one thing that I definitely agree with is the notion of resistance to vaccines. And I think that's a tremendous problem, both in the United States and, I mean resistance not in terms of the vaccine not working, I mean resistance in terms of people not being interested in becoming vaccinated. And as you know, for better or for worse, I use the occasion of my inauguration to point out my acceptance of H1N1 vaccine and how important I thought it was for our students and healthcare workers to become vaccinated. I still, believe very strongly that this needs to be done, and that much of what is out there that is contrary to vaccines is usually not based on any form of effective scientific evidence, yet the demonstration of their efficacy is clear to anyone.
Yes, Jim.
Can I just make a follow-up to both Sam and Adel's comments that I think the word eradication is what really kind of sticks in Adel's craw about this. It sticks in my craw. But I do understand that I think you need this for stakeholders' perspectives, because people want to invest, whether it's our government, the European Union, the Gates Foundation, something that will have the potential for really solving the problem. But the front page of the Sunday Times yesterday talked about the war on cancer again, okay? And albeit this is a much more important problem for the American people than malaria is when you look at it from an immediate health perspective, okay? On the other hand, malaria may be more important for political stability and terrorism than cancer is in terms of alleviating poverty and stuff like that in the hotbeds where terrorists grow up. So I think that the word is important as a ultimate goal, and it keeps people on track to keep trying, because even though malaria eradication really is probably not biologically feasible now, it's no question that bed nets and the reintroduction of indoor spraying with insecticides has done a tremendous amount to reduce childhood mortality in sub-Saharan Africa and other parts of the world. So we have to keep at that, because even though it's a drop in the bucket of U.S. funding or of European funding, but it has such an important effect. So I think we need to keep this at least, as opposed to once per year, perhaps it'll be the front page of the Sunday New York Times, at least to keep our politicians and stakeholders and funders aware of these kind of things.
Margaret Chan, the head of the World Health Organization, I think a couple of years ago said, this debate about vertical programs like PEPFAR, like eradication of polio, et cetera, versus horizontal programs, building up healthcare systems, strengthening health systems so they can attack all of these things across the board. This debate is over. Everybody agrees we have to do it all. We have to have some vertical programs, just as you said, to keep stakeholders and others interested. We have to strengthen healthcare systems, and now increasingly people talk about the diagonal, basically doing both of this all the time. Do all of you agree? Is that where we are? And does that help us to think about?
I was in a meeting last week
diagonal?
at the Japanese Society of Tropical Medicine, and they had the person who's in charge of PACL. This is the Pacific Program to Eliminate Lymphatic Filariasis, okay? She's now, so they've reorganized the WHO for about the 18th time in the last 5 milliseconds again. But in any event, she's now the director of the Integrated Vector Management. So this involves mosquitoes, it involves snails, it involves bugs that transmit Chagas disease and these other kind of what we call of exotic things, but they're important in South America, et cetera. But at least it's addressing the fact that vectors are important. So even though it's not a lot of money that it requires, but it keeps people that one aspect of controlling these infectious diseases, and some of the cancers are truly infectious themselves, I might add, is to control the vectors, okay? So it's not the magic bullet, but we don't have any magic bullets. So at least we have to keep up the different parts of the puzzle, at least keep the battle going.
What do you think, Adel?
I just, I mean, he's getting to be a politician with this. Sorry, continue. So, the issue here is not vertical and horizontal and diagonal. I mean, we love these descriptive definitions, which in many ways help, but really do not. The facts of life are policies that are not based on scientific foundation are dangerous policies. Are dangerous because it misleads and raises hopes and then deflates them. If we tell, this is exactly what happened in West Africa. We told the countries around northern Nigeria, there are 8 or 9 countries bordering northern Nigeria, stop polio vaccination because you eliminate it. Okay? One episode in northern Nigeria resulted into the Muslims of northern Nigeria saying this vaccine has got an anti-fertility component, so they stopped vaccination. So we now have, within 1 year, polio in 9 countries. Okay? Now, this is because we are putting blinders and claiming there is something called eradication. This country has not stopped polio vaccination up till 2009, and we probably will never stop it. Why? Because the policy is control it. Keep vaccinating every cohort against polio, measles, mumps, so as any infection that comes from any other source, we can control it. And that is the reality of the world. Reduce the sloganeering and be pragmatic. We're going to control. I mean, the achievement of the WHO campaign against polio is phenomenal because we used to have millions of kids with paralytic polio. Now we have about 1,000. Okay, I'm prepared to live with 1,000 paralytic polio and control polio this way and move on to something else. So that's issue number one, and it is very dangerous. And since we are in a medical environment here, it's really dangerous to have policies that are based on soft science. Okay, it's one thing to say eradicate malaria. It's another when the last hope of the drugs against malaria, resistance against it already showed up in the border area between Cambodia and Thailand. So a year ago, you talk to them, how are you going to eradicate malaria? They say, artemisinin combination therapy. Okay? It's now resistance started. In the same area, chloroquine resistance started 30 years ago. Do we want to learn from our scientific experience, or we just want to sell sloganeering?
Okay, everybody who votes for sloganeering versus science, please stand up. Okay, I think we know the answer there. Thank you, Adel. Well, while we're on this topic of microbes, which we are rather hubristic, as Adel implies, to think we can ever get the best of, a questioner in the other room wrote that it seems that one kind of stovepiping is evident in this panel in the emphasis on infectious disease alone in global health. Do you see a bias in the current funding and institutions devoted to global health against or in favor of infectious diseases and against those modern Western ailments that are becoming such problems in India or China? For example, obesity. There are more obese people in China than there are in the United States of America at the moment. Not surprisingly, because there are many more people in China. But nonetheless, is there a bias? I'm asking several infectious disease people here whether they think this is biased against infectious disease, but go ahead.
Biased against infectious
Or
disease?
a bias in favor of infectious disease against Western diseases, Western, in quotes, diseases.
Yeah, I think at this point it's justifiable. There was a paper last week in the New England Journal of Medicine about what's the next, these are my words, what's the next best thing in global health? It's urbanization. So, and it was really about life expectancy, infant mortality and childhood mortality in Nairobi. And they compared, so when I first went to Nairobi in 1974, you could walk around central Nairobi. It was a city probably of 750,000 people, which is what that city was built for. Now there's 4 million people. I drove to northeastern province, 2.5 hours out of central Nairobi. There's squatter villages where there's 2 million people living, no toilets, no power, cholera, in addition to all the other usual urban ills like violence and things like that. That's where the action now is still in developing countries, like in many parts of Kenya. When you look at people who live in affluent parts of Nairobi who are African, their infant mortality is similar to that in Western Europe, not as bad as in the United States, but similar to that in Western Europe. So I think it's justifiable that we still focus a lot of our resources in those settings on infectious disease. At least that's my opinion.
I don't know if there's somebody in the audience who wants to take the opposite view, or Dr. Stanley, why don't you?
Unfortunately, in that, I look at it in part from the perspective of children, in terms of what are the diseases right now that have an impact on children. Again, I would say malaria, HIV, the diarrheal diseases have a significant impact. I would agree that childhood neonatal mortality women's health also should be very high in that generally. And I'm not saying that we don't need to take a look, because again, as I said in my introduction, I think the things that we're doing currently in terms of approaches would potentially prevent diseases like diabetes, particularly in the triad of diabetes and cardiovascular diseases, increasingly important. I think we need to start exporting some of our concepts about how does it make you stay, well, that is the world as well. But if you start looking at those diseases that have a disproportionate impact on children, the infectious disease provides support. For that reason, I think it's not unreasonable to make
What about nutrition, though? Because nutrition is a factor in about 40% of those childhood deaths around the world. Why aren't we giving even more attention to that?
I think it is important, and I think that again, there's a lot of work going on currently that's looking at this, between malnutrition and obesity and how calories including the arteries. And I think it's important area for basic nutrition and investment. I think probably my lens would be, what are the things that right now have a disproportionate impact on risk of potential life loss? And I think those are the things that we tend to focus on.
Let's take a question here.
I'm not really being a contrarian to this because I'm an infectious disease specialist. And what you're seeing is the outcome of bad infrastructure. So a lot of the solutions to these global health problems are by recreating the infrastructure to prevent them. No sewage, no sanitation, no water, no access to education leads to these diseases, which then, as Dr. Stanley said.
Here's a microphone.
As Dr. Stanley said, you know, the breakdown in health leads to political instability. It's a two-way street. Most of the countries that are underdeveloped have bad governments. So you have both things going on simultaneously. So I think, so the analogy is pulling people out of the river and then walking up and finding out who's throwing them in. We're in the medical profession, we're pulling them out of the river with our infectious disease stuff. That's the outcome. But what the heck's going on upstream that's putting them in the river? And it's usually a breakdown in infrastructure. So many of these things require engineering input, social change, and those are the kinds of things that I think are coming to the forefront in global health now.
Great comment. Let's take another question or comment here. And if you would introduce yourself by name and affiliation, that would be terrific. And use the microphone. Thank you.
Arthur Grohlman, I'm a professor of pharmacology and medicine. There is another initiative that's been going on for some time with great relevance to global health, and that's environmental health science. The NIEHS started in their strategic plan 6-7 years ago, placed it in there. They work very closely with Fogarty, who is in many countries there, and they do so, and if I remember the figure, 50% of all deaths globally have an environmental component, and 33% can be directly attributed to the environment. So clearly, we can't limit it to infectious diseases. This is a program, and by the way, they fund at the 20th percentile, which means their research programs get going a little easier than when they're at the 6th. So that's a plug for environmental health, and you could make a similar thing for cancer as well.
Comment from any of you?
Yeah, I think that you're absolutely right about that. And I think that, for example, if you look at, theoretically, there's been recent papers looking at Tamiflu. And if there was an epidemic where a large number of people were taking Tamiflu, actually it was modeled after situations in New York and other American large urban areas in Western Europe. And if there was like 40% of people took Tamiflu, how would this be when people flush it down the toilet, where it would find its way into groundwater? It's predicted that at certain proportions of the population using it, it would rapidly select for resistance against Tamiflu. That's one example. A second example, I just wrote a grant on malaria in the Amazon, which is spreading like wildfire. It's related to the construction of hydroelectric dams. So it relates to infectious diseases, because that's my area. I'm sure there's other areas, or it can be related to toxins that produce cancer. But you can predict pretty well where the vector, which is Anopheles darlingi, as soon as you start changing the patterns of green and rainfall and things like that, the vectors go right up and you have outbreaks of malaria. So these are not, this is an example where we're much more sophisticated now than we were certainly 15 or 20 years ago from an informatics perspective, and seeing how these various tools outside the immediate biomedical field can inform us for health problems in general.
We've touched a little bit on the topic of climate change, and Congressman Bishop, I'd love to pull you into this part of the discussion. We know that global climate, I'm picking all the easy topics for you, throwing them your way. We know that global climate change is going to have enormous effects on human health, already is probably having enormous effects, already is having effects on the poorest regions of the world. It is not going to help the malaria situation for the world to get warmer, just to state one obvious factor. And yet we have a political structure in the country that is still having a lot of trouble coming to grips with what the implications are for reducing our own addition to the global climate change problem through our energy use patterns, et cetera. The House of Representatives obviously took on the energy bill and voted. The Senate is still grappling with this. It's not clear whether any legislation will pass the Senate this year. How do you think we're going to come to grips as a country to making the kinds of serious changes that we're going to have to make, and in persuading a lot of other countries around the world to make those changes as well, so that we can really reduce the threats to global health, not just in the near term, because the ones that we're going to see in our lifetimes are probably pretty much now baked into the cake. We're really talking about making the world a safer place for 2 or 3 generations down the road.
Yeah, you are taking all the easy ones.
Yeah, right.
A couple of things. As you say, the House has passed a bill, very controversial, passed by 7 votes. The Senate is looking at a similar bill. And I have a hard time believing that it will get through the Senate, very candidly. I mean, the Senate, as you probably know, needs 60 votes to pass anything, unless it is protected by another inside the Beltway concept known as reconciliation, and the climate bill is not protected by reconciliation. So I think it's going to be very hard politically, and it is, the degree of difficulty has increased enormously given the juxtaposition of climate change legislation with healthcare legislation, and given the difficulty in estimating the cost. There are various estimates. I mean, one cost of the of the Senate bill is that it would cost the average family about $100 a year. The House bill was projected to cost about $170 a year for an average family. Those are very tolerable numbers. There are other studies out there that say it will cost the average family $1,800 to $2,200 a year. That's not a tolerable number. And when you take those numbers and put them with some of the more worst case projections for what healthcare reform will cost, you get a situation that becomes at least politically untenable. So, you know, I'm not real good at predicting the future, but I think we will probably do some, if you'll forgive me, nibbling around the edges with climate change. I think we're going to have a hard time getting to either a cap and trade system or a carbon tax system. I think there will be some greater investment in carbon capture and sequestration. I think there will be some greater investment in wind and in solar. You'll see renewal of tax credits. You'll see more. You'll see probably what's called a renewable portfolio, renewable energy portfolio, meaning that power companies will have to generate a certain percentage of their power from renewable sources by a certain date. You'll see increases in minimum fuel efficiency standards and so on. But whether we're going to get to the core issue, which is to put a price on carbon, that's the core issue. And by far and away, the most difficult to achieve. I think that is unlikely, at least in this session of Congress.
And what did the rest of you think are the implications for the world then of that happening, and particularly of the health impact, the global health impact that, according to the International Panel on Climate Change, we're already seeing play out throughout particularly poorer regions of the world?
The one clear example is the spread of dengue, which is a viral infection that years ago was on the decline because of the effort to control the mosquito populations in many parts of the world. So with that decline in mosquito population, there was a reasonable decline in dengue. Now, when you look at the map, for example, of Latin America, it's back infested with the two mosquitoes that can transmit dengue, and there is a lot more dengue in Latin America, the same in Southeast Asia. So whether the increase in the mosquito population is simply because of the lack of control measures or decrease of control measures, or an expression of the global warming, it's a little bit controversial, because obviously with the disappearance of DDT as an important insecticide, there was less effort to go after the mosquitoes. But there is no question that you're seeing a lot more dengue than we've seen, and it is transmitted by a mosquito that needs a little bit of higher temperature to survive.
So the implications are not good, to put it briefly, of us not.
I mean, really serious.
Okay. We have a few more minutes for questions before I'm going to ask the panelists to make some closing statements. Let's take one in the rear here.
My name is Ikal from Kenya. I'm doing my master's here. My question to the congressman is that while we push for funds to go to developing countries like Kenya, how do you make sure that these funds get out of the city, as Dr. Kazura said, and into the people who really need the funds? Because we send money, a lot of money comes from the States. It gets to Nairobi. It doesn't get to northern Kenya, where I come from. So how do you then make sure that happens?
Well, the congressman gave me that question to handle, but it's.
I did the talk.
Right, okay, you did. Okay, to be honest with you, I think that what the same thing is true with anti-malarials, to use another example, okay? So there's papers, I'm the editor of the American Journal of Tropical Medicine and Hygiene, and some very prominent malaria researchers were Kenyan, submitted a paper, which I knew would be controversial, but it's like, so Kenya got all these drugs, these artemisinin combination therapies for treatment of children, but if you go to rural clinics in I work near Kisumu in Western Kenya, they didn't have the damn drugs there, so where were they? They were being sold, okay, with some graft and things like that, okay? So this is true, there's less fat in the system in Kenya than there is in the United States. It's not unique to Kenya graft, it occurs everywhere in the world to varying degrees. But I think one way that PEPFAR, at least in and I'm not involved in PEPFAR, but my experience is that it's really tracked very carefully now. It's often done through NGOs, which have their own problem, okay? Because NGOs then kind of disenfranchise the Ministry of Health for taking primary responsibility, so it's not indigenous. But if the Ministry of Health...
You're talking about international NGOs.
Yeah, international
having
NGOs,
that
okay?
implementation.
Or they subcontract with the Centers for Disease Control or with Walter Reed, who we work with because they have a strong research presence there. So they deliver it in those kinds of ways. What part of Kenya are you from? From Turkana. Well, that's a tough place. Okay, that's a tough place, right? But that's been true. It's ignored by the Kenyan government in general. Okay.
But I was looking at Ikel's poster earlier. She's here now and intending to propose a project that would actually empower community health workers in Kenya, in the Turkana region, to do much more, particularly with the advantages of e-health, new technologies that will enable community health workers to deliver a level of care, frankly, that could be provided any place now because they've got the technologies right in their hands. So there's hope, right? There's hope in Turkana. Any other question here, please?
I have a question that's sort of parallel to that, and that is we sit here and make priorities, and I'm wondering whether it's the value of life, or morals, or ethics, or even the distribution issues that are coincident with the places we're talking about. If someplace else in the world does not value life in the same sense we do, how can we make priorities for expenditure of any resource here more than and expect it to work?
Wants to take that on.
We shouldn't make priorities for anybody else but for ourselves. And when we want to work with the rest of the world, we have to gain their confidence, their commitment, and look into their priorities with them. I mean, it is absolutely anti-logic to try to say, here is the list of priorities from a U.S.-based point of view, and I want to force it down the throat of the people anywhere else in the world. It doesn't work. You're absolutely right. So, I mean, one of the difficulties, and the question about Kenya, one of the difficulties is we are facing a very difficult global map. I mean, the rest of the world is not as uniform in their leadership, in their commitment to democracy, in their commitment to leadership, commitment to prioritization, the way we think. So you go and work with government X. Government X has its own priority in many ways. And sometimes it's not even necessarily based on science. It's just based on what the president wants or what the ex-minister wants. So this is where diplomacy, I mean the US diplomacy, the US politics, and the science, and everything has to work together because it is part of the I mean, in some ways the success of PEPFAR was because we have a lot of money and we have a very focused program and we work through avoiding, in many ways, the government. But you can do that all the time. I mean, you really have to work with the people and the governments of those countries. It used to be told to us, we are doing X disease because that's what the funders want. And that is a very, in many ways, very difficult thing to accept globally.
Anyone else?
I'll just make a quick comment. I mean, I think one of the things that we recognize is that it is incredibly important to have a degree of cultural sensitivity. It's one of the reasons that anthropologists and sociologists, I think, have become so important as we look at what we're doing. Having said that, I think there's some fundamental principles that I think there's very few societies that I'm aware of don't embrace, and among those is generally goals and aspirations for their children, hope for their lives and their futures. And I think that, that is universal enough, the value of lives and the value of individual lives, that I think is a reasonable starting point as we look at working with others.
All right, well, as we wind to a close, I'm going to tell you all that I had very good fortune over the weekend. I went to Best Buy, and they had in stock crystal balls, $19.95 each. So I bought 4 of them. You have them under your table there. I'm going to ask you now to look into those crystal balls and tell me, what are the next 10 years going to bring in global health? I talked a few moments ago about what the last 10 years have brought. What are the next 10 years going to bring? And what are the major challenges and opportunities that particularly the younger people here in this audience will be able to take advantage of in the next 10 years? You can either offer them an opportunity or a challenge, whichever one you'd like to pick. And Adel, let me start with you.
I would hope that the next 10 years in global health will bring the involvement of a new generation of U.S. citizens, and not only the medical, but the total U.S. power and commitment and dedication to lead in this world, because the world is lacking leadership, and without America, we really cannot do it.
And so the challenge or the opportunity for them is?
Get involved.
I think you've got a lot of believers in the audience already. Jim, what do you think?
Well, first of all, I think that there will actually be formalization of departments, if you will, of global health within universities, and actually several universities have made significant commitments to do that. The form of that is still being developed. They have a program, they try to form a school of global health in the University of California system. It's a problem right now because there ain't any money there to do it anymore. It's a virtual thing, but it was amongst the different UC schools. So I think that'll happen. I think the other thing that will happen, related to what the congressman was saying, is projection of soft power will be increasingly important, whether it's in the next Obama administration, if there is such a thing, or whether it's in the next Congress and it's a different president. And I think we'll see. We talked a lot about us getting exposed to global health. I think we'll hopefully see, to me, one of the very enriching parts is having people come. We need, to learn it, you have to go there. So you can read all you want about it. I think you need to, our students and our faculty need to experience it, but I think we'll see increasing number, hopefully, of students coming over here. And that was curtailed right after 9/11. I think and my hope is, my prediction, that will open up, particularly to students from developing countries.
So the opportunity then is for more of that to take place?
Yes.
Yep. Okay. Congressman Bishop, I know this is not your day-to-day area of thought, global health, but what do you think is coming down the pike?
You're right, it is not my day-to-day, or certainly not my area of expertise, but I would, which I've demonstrated, by the way, quite handily so far this morning. I would say that I believe there will be continued effort on the part of the United States to exercise a leadership role. I think that effort will be tempered. I hope not too drastically by some debilitating problems here at home that we simply must confront, and we will have great difficulty in confronting. And as to the next generation of those who will carry us forward, I would just echo what Adel said, which is to get involved and to make a difference. And you are well on the way to doing that. So, and I thank you for what you're doing.
And now, Dr. Stanley, I'm going to give you something that a university president almost never has, which is the last word.
I'm going to enjoy it. I'll come to this from the perspective of, I think, all of the things that were said previously, because these are three very smart people, and I think they all have words of wisdom for us. I do, as I said in my comments, have tremendous enthusiasm about the future, because what I have seen from our students and from the youth, which is really this notion of really, I think, maybe our first global generation. I don't know if it's Generation Y or what we want to call it. But there really has been, I think, really for the past decade, as I've seen, a recognition of the fact that health issues really do not know boundaries, that as a physician, as an allied health professional, you need to look beyond the United States, because there are absolutely urgent needs, and I've been very encouraged, I think, by that. So I think there will be a continued drive within our profession to move things forward. And I think for the U.S. as a whole, this economic challenge, I think, creates a couple paths. And I think one path is to say, things are really tight. We have to look within. We have to get our own house in order. We have to really take care of our problems here. And if we do that, we'll be better prepared in 4 to 5 years and whatever it takes to get out and really start making differences again. The other way is to say, it's not just our problems. These are global problems. The way to deal with them is going to be invest in solutions that not only for the United States, but to learn from what's happening in other places and really try and push outward to the extent we can. And I think there are very strong arguments in each way, but you can tell from my comments previously that I still think investment in fundamental research, I think investment in innovation, and innovation really is at the heart of solutions to many of these problems. So when you talk about global warming, when you talk about the problems of energy, I think the solutions in many cases rely on new approaches, new technologies, but also new ways and processes of doing things. So I think, to me, continuing to try and invest in innovation will have a positive impact not only on global health, but many of the other issues we have. And so my hope would be that we're capable of a country of making that kind of commitment, recognizing that the long-term payout will be significant. And I hope Stony Brook can play a small part in that as we move forward.
Well, and as I mentioned, having read the university's mission statement and learning that part of the goal of the university is to position the university in the global community, I think it's clear from today's discussion that much of that has already been accomplished. The global community is right here in this room. And I saw it today in the poster presentations. You've heard it, obviously, in the remarks that have been made this morning. Let's join me now in thanking this panel for a terrific discussion.